Sarin, designated chemically as GB, is a highly volatile, highly lethal G-series nerve agent. Because it evaporates rapidly into a dense, invisible gas, it presents a severe inhalation hazard in both open tactical environments and enclosed civilian spaces. German chemists at IG Farben originally synthesized the compound in 1938. They were attempting to develop a stronger agricultural pesticide, but the extreme human toxicity of the chemical quickly diverted it into military stockpiles. The most documented civilian mass exposure occurred in 1995, when the Aum Shinrikyo cult released sarin on the Tokyo subway system. The rapid onset of nerve agent casualties flooded local hospitals, quickly overwhelming triage protocols and depleted specific antidote supplies. In military contexts, sarin was deployed during the Iran-Iraq War, and thousands of coalition troops faced exposure following the destruction of the Kamisia munitions depot. More recently, it has been used as a chemical weapon against civilian populations during the Syrian civil war, causing mass casualties in densely populated neighborhoods. Because sarin is highly volatile, it easily off-gases from the clothing and skin of victims. This turns the patients themselves into secondary exposure risks, frequently poisoning the first responders and nurses attempting to treat them. Medical personnel cannot rely on the assumption that chemical weapons are strictly battlefield problems. The clinical reality requires civilian and military emergency teams to be prepared for unexpected, high-volume exposure events at any time. This layout maps the acute sarin toxidrome using the mnemonics sludge and dumbbells. These categorize the rapid, systemic cholinergic crisis, where the patient loses control over exocrine glands, smooth muscles, and the central nervous system. The immediate presentation includes profound diaphoresis. The patient breaks into severe sweating, with aggressive gastrointestinal cramping and emesis. This rapidly escalates into acute respiratory distress. The patient's airways hypersecrete fluid, while the smooth muscles of the lungs tightly constrict in a severe bronchospasm. The patient effectively drowns in their own airway secretions. When exposed directly to sarin vapor, a hallmark clinical sign is miosis. As the ocular muscles spasm, the pupils rapidly constrict to pinpoint dots. As the poisoning progresses into the neuromuscular junction, the patient exhibits violent muscle twitching, known as fasciculations. This degrades rapidly into complete flaccid paralysis and respiratory failure. The severity and speed of this physical collapse often lead to the clinical perception that nerve agents act too quickly for medical intervention, making rescue seem biologically impossible. Recognizing this specific toxidrome is the difference between life and death. Contrary to the assumption of immediate universal lethality, sarin provides a definitive biological window for pharmacological intervention. To understand that biological window, we have to look at the synaptic cleft, the microscopic gap between nerve cells where signals are transmitted. In normal physiological function, the presynaptic nerve releases acetylcholine, represented here by these spheres. They travel across the gap, bind to receptors on the other side, and trigger an action, like a muscle contraction or a glandular secretion. To stop that signal, an enzyme called acetylcholinesterase, or ACE, acts as a chemical reset. It rapidly binds to and breaks down the acetylcholine, clearing the cleft so the muscle can relax. When sarin enters the nervous system, it demonstrates an extreme affinity for that exact enzyme. The sarin molecule forms a covalent bond with the active site of the acetylcholinesterase enzyme. It physically jams the mechanism, neutralizing the enzyme's ability to process neurotransmitters. Without functioning acetylcholinesterase, the acetylcholine has nowhere to go. It accumulates rapidly, trapping the nervous system in a continuous, chaotic firing loop. This flood overstimulates the muscarinic receptors throughout the body. This is what forces the lungs, the salivary glands, and digestive tract to produce the massive secretions and smooth muscle contractions seen in the clinical toxidrome. Simultaneously, the flood bombards the nicotinic receptors at the neuromuscular junction. The continuous stimulation exhausts the skeletal muscles, causing the initial twitching and ultimate flaccid paralysis. This initial covalent bond between the sarin molecule and the enzyme is catastrophic to the nervous system, but chemically it is momentarily reversible. Sarin achieves lethality by turning the body's own neurotransmitters into a persistent, uncontrolled flood. The temporary reversibility of this bond introduces the most critical concept in organophosphate poisoning, a biochemical process known as aging. After the nerve agent binds to the enzyme, the complex undergoes dealkylation. It drops a specific chemical group, causing a secondary conformational change. Once this shift happens, the nerve agent is permanently locked into the enzyme. Clinically, once an enzyme has aged, it cannot be reactivated by any antidote. Recovery then depends on the body naturally synthesizing new acetylcholinesterase, a process that takes far too long to prevent respiratory failure. This comparison shows that different nerve agents age at drastically different rates. We can compare the aging speed of Sarin against a closely related G-series agent, soman. When soman binds to acetylcholinesterase, the chemical structure dealkylates almost instantly. The enzyme fully ages in approximately 2 minutes. The 2-minute soman window provides almost no time for field rescue, reinforcing the perception that nerve agent exposure is universally and immediately terminal. But Sarin's molecular structure reacts differently. The initial bond holds, but the secondary conformational change that locks it in permanently is significantly delayed. The aging half-time for a Sarin-inhibited enzyme is roughly 3 to 5 hours. This hard data directly counters the assumption that medical intervention in a chemical mass casualty event is futile. That 3 to 5 hour delay is the definitive pharmacodynamic window. If emergency responders act within this timeframe, pre-hospital pharmacological rescue is highly effective. To exploit this window, responders utilize a standardized field countermeasure, the Mark 1 kit. It contains 2 medications in separate tubes, atropine and pralidoxine chloride. These are designed for rapid intramuscular deployment. The injector is pressed firmly into the outer thigh, delivering the drugs directly into the systemic circulation. Returning to the synaptic cleft, we observe the mechanism for atropine. It acts as a competitive antagonist, rapidly binding to muscarinic receptors and physically shielding them from the acetylcholine flood. This halts the glandular overstimulation, allowing the patient to breathe. However, atropine does nothing to repair the inhibited acetylcholinesterase enzyme, nor does it affect nicotinic receptors. The patient's skeletal muscles will remain completely paralyzed. Atropine is strictly a temporizing measure. It keeps the patient from suffocating to death on their own fluids, securing the airway and buying the clinician time to deploy the true antidote. The second phase of the dual-vector attack relies on the drug pralidoxime. Pralidoxime belongs to a class of compounds known as oximes. While atropine manages symptoms, pralidoxime goes directly after the source of the toxicity, the jammed acetylcholinesterase enzyme. The oxime exerts a powerful nucleophilic attack, chemically bonding to the Sarin molecule and physically prying it away from the enzyme's active site. This breaks the covalent hold, fully reactivating the enzyme to clear the excess neurotransmitters. But this mechanical reactivation has an absolute biological limit. It only succeeds if the pralidoxime is administered before the 3 to 5 hour aging process permanently locks the Sarin molecule into the enzyme. These clinical guidelines dictate aggressive initial dose titration, followed by continuous intravenous infusion, ensuring the oxime therapy reaches paralyzed enzymes before the aging window closes. As the nicotinic function returns, the severe fasciculations subside, the paralysis breaks, and the patient's spontaneous breathing rhythm stabilizes. The medical response requires both factors to succeed. Atropine secures the airway to sustain life, while pralidoxime targets the enzyme to eliminate the chemical threat. Understanding the pathophysiology and the specific 3 to 5 hour aging window allows medical professionals to successfully intervene in a lethal cholinergic crisis.